Okay, welcome everybody to a LyfeMD educational event that's being hosted by myself, Charlie Corlett, and I'm the lead coach for LyfeMD. So I speak to many of you and welcome you on board when you come in. And then I'm also your go-between between our two GI specialists, Dr. Raman and Dr. Tandon. So when your questions come to me, they then go to these lovely people and they get their answers for you. And also I can help there provide if there's questions that you have for dietitians as well. So that's my role and where I sit with this. What I will do today is I will be reading the questions because some of you may be joining via your phone or can't quite read if you're joining from your phone, you might not be able to read the questions on the slides. We've had a lot of questions that came in yesterday, so thank you for all of those. The purpose of recording this is so that we can share this on our YouTube channel afterwards. That gives people the opportunity who are not able to make this live session. They can then view it again. And that's where we'll also post our other videos as well that we've been making. So I know some of you joined us for the Christmas advantageous eating session with Dr. Laurie and Taylor. And we've already had some other sessions by Dr. Raman as well. So this session came about as Dr. Raman suggested a bit of a fireside chat just to listen to your GI questions and see if we can help to answer them. And it's good that winter's just poked its head back up again for most of us around here. I think we've had some parts of BC and Alberta have had over 30 centimeters of snow today. So it does feel like it's a very aptly named title. Dr. Raman, Dr. Tanner, would you like to introduce yourself? And then I'll move on to the first slide.
Sure, happy to. So welcome everyone. Thanks for joining us this evening. My name is Maitri Raman and I'm a gastroenterologist and associate professor at the University of Calgary and also co-founder of LyfeMD. And really happy to be with you all here this evening. And I'll pass it over to Dr. Tandon.
Thanks, Maitri. Yes, nice to see everybody on the call. So my name is Panita Tandon. I'm a hepatologist, so a liver specialist. And I work at the University of Alberta, and I'm also co-founder of LyfeMD. So thrilled to be here.
Okay, excellent. So what we've done is we've sort of segmented some of the questions into some areas that we're able to sort of break down and try and go through this way. And we'll see how far we get with them because there are a lot. So thank you for these. So the first one is, what are the scientific differences between colitis and Crohn's? For example, what is going in the bowel with ulcerative colitis compared to Crohn's?
Okay, so I can take that question. That's great and a very common question. So basically, when we think of the term colitis, we think about inflammation that involves the large intestine. So if you remember, we eat food, it goes into our swallowing tube, the esophagus, and then it passes through into the stomach, and then it goes through the 500 to 600 centimeters of small bowel where the majority of digestion and absorption happens, and then nutrients and waste products then fall into or flow into the colon or the large intestine. So when we think of the term colitis, we think about inflammation that's really limited to the large intestine. But when we think of Crohn's disease, we think Crohn's we typically think of as a condition that can affect anywhere from bum to gum. So it can affect any part of your GI tract, starting with ulcers in the mouth, ulcers in the swallowing tube, all the way down to ulceration and inflammation in the large intestine. So the primary difference between ulcerative colitis and Crohn's disease is the location in the GI tract that it affects. The other major difference between Crohn's disease and ulcerative colitis, and I'm being specific about the term ulcerative colitis because there are many different types of colitis. So if you have food poisoning, for example, or you contract an infection that affects the large bowel, that can also be called colitis. But the way we're using the term colitis, I think, for the purposes of this conversation is ulcerative colitis versus Crohn's disease. So from a broad perspective, Crohn's can affect anywhere from bum to gum, and colitis is limited to that large intestine. And the other major difference between the two, So the bowel wall has multiple different layers. So when we do a colonoscopy, for example, we see the innermost layer. But there are at least 3, 4, 5 layers of the small bowel as well as the large bowel. So Crohn's disease, that inflammation in the colon, or in the bowel of someone with Crohn's disease, it can affect the entire wall of the intestine, not just the innermost layers. So some people with Crohn's disease may develop complications like fistula, which are connections from one part of the bowel to another part of the bowel, or patients with Crohn's may develop abscesses or pockets of infection. And this is the major reason why, because the full thickness of the bowel is involved, not just the innermost lining.
And that's why they get that fibrosis, that stricturing as well, right? With Crohn's, that doesn't necessarily happen with colitis.
That's a great point, Panita. And that stricturing, oftentimes, if that stricturing or that narrowing, that blockage is there over time, it tends not to be responsive to medications, including biologic medications. So these strictures are what eventually may lead towards bowel blockage symptoms that could result in surgeries.
Mm-hmm.
Thank you. How does a GI doctor determine whether a patient has colitis compared to Crohn's, since they are similar and both classify under IBD?
Yeah, you know what? This is a great question. And really, it comes down to multiple types of diagnostic tools. So by listening to your story, your history that you provide us with, by looking at the blood tests, looking at the stool tests, and then colonoscopy, of course, is front and central towards making this diagnosis. And then in certain parts of the country, depending on where you are, you may have access to other diagnostic tools, such as a cross-sectional MRI or specialized MRI of the bowel, specialized CT scan of the bowel, or a specialized contrast-enhanced ultrasound of the bowel. So there's no one tool that we can use with certainty to make this diagnosis. It truly encompasses all these different components or different tools to do this in an accurate way. And even despite the best efforts, sometimes we misclassify disease, or we think at the time of diagnosis that there is a diagnosis of Crohn's disease or ulcerative colitis, only to find out later in the patient's journey, maybe 5, 10, 15 years down the road, that in fact this wasn't colitis and this was indeed Crohn's disease. So agree that making the diagnosis is challenging. Anita, do you have anything to add to that?
No, I think that's great. Yeah, we definitely look at a lot of things when we're making it. Sometimes it is more obvious, right? Like if it's extending into the small bowel quite high up, or if there's skip lesions, I suppose, then we would think more of Crohn's. So there are things that tip us off that it's one versus the other, but it's a really thorough workup.
Right. So is there an overlap in the two diseases where a patient is diagnosed with both? And at what point will the doctor make that diagnosis of both diseases?
Okay, so maybe I'll start by saying, so if you recall, I told you the major difference between Crohn's and ulcerative colitis is the part of the bowel that's involved. So what that means is that patients with Crohn's disease can still have their colon involved. So if you have Crohn's, you can still have something called Crohn's colitis versus ulcerative colitis. So colitis, in fact, is that general or that generic term whereby we refer to inflammation in the large intestine. So if a doctor makes a diagnosis of both diseases, likely what it means is that they don't know at that point in time what is driving that inflammation, whether that's Crohn's disease or whether that's ulcerative colitis. But, and in a situation that's indeterminate like that, we call it exactly that, indeterminate colitis or unclassified colitis. So with certainty, we will be able to diagnose ulcerative colitis about 80, 90% of the time. Similarly, with Crohn's disease, with certainty, we can diagnose it about 90% of the time. But there is a 10 to 15% of individuals where it's not clear. And in that unclear period, the diagnosis will often be indeterminate colitis.
Thank you. So I'll move on to the next slide and just make sure I've got the right one. So what are the biomarkers, lab tests, and diagnostics that help determine whether a patient has UC or Crohn's disease, as both these diseases have very similar and overlapping signs and symptoms?
So I may have probably discussed most of this in the previous questions, but to be specific, there are tips that, or there are clues in the blood work that can tip you off as to whether one has inflammatory bowel disease versus another condition. Now, are there blood markers that may tip you off whether one has Crohn's disease versus ulcerative colitis? I would say less so, but things that we typically look at would be your hemoglobin, your white blood cell count. There are inflammatory markers like your CRP or C-reactive protein. There are nutritional markers like the albumin, which reflects protein in your blood and is reflective of your overall protein stores. And then there are electrolytes, and the common electrolytes that we would measure would be things like sodium, potassium, but then there are these extended electrolytes like magnesium and phosphate. And we look at clues and patterns in the blood test to help us determine not just the diagnosis, but also the severity of the inflammatory burden, as well as the part of the bowel that might be affected. And beyond the blood tests, as I've mentioned, the colonoscopy is critical, the gastroscopy or the upper endoscopy, whereby we go in through the mouth and look at the upper GI tract, that can also provide another clue. And then ultimately the range of cross-sectional imaging, ultrasound, CT, MRI.
Thank you. Has there been a case study or studies showing patients who have recovered and healed their bowel completely and no longer have IBD?
Right. So I guess I can answer this two ways, both with and without medications. So in 2023, compared to, let's say, 20 years ago, we now have a whole line or a whole suite of medications that are successfully used to manage inflammatory bowel disease. Typically, the bottom line is there are no medical cures for inflammatory bowel disease, but certainly there are very, very long-lasting remissions. Now, if someone truly has a diagnosis of ulcerative colitis, and we're clear that this, in fact, is ulcerative colitis and not Crohn's colitis, then surgery is a cure in this particular context. And by cure or by surgery, I mean removal of the entire colon. So proctocolectomy, where the rectum and the colon are completely resected, and one is left with an ileostomy or a J pouch. In that situation, we would say that patient has been cured from their ulcerative colitis. But let's say we have a patient with ulcerative colitis and they've not had surgery, but they've been on any of the number of biologic agents that we have, or even non-biologic agents, because there are several non-biologic agents that can be used. Typically, we won't necessarily say that that person has been cured from their disease. We would say that they have a lasting and a deep remission. Okay. So I would say, I would say that's how we view things. Panita, do you have any comments on that?
Yeah, no, I would agree. I think we're all hoping for a future where there is healing, obviously the complete healing, but at this point, Maitri, I completely agree with what you said.
And, and to your point around we're hoping for a future for cure. And this is the motto at the end of the day by the Crohn's Colitis Canada Foundation, the Crohn's Colitis Foundation of America. We're all seeking the cure. We don't have one yet.
Okay. If one antibiotic has been prescribed for a few months and then it is stopped for a period of time because it is no longer needed, will this same antibiotic be effective the next time?
I would say generally yes. So it's not like potentially other medications whereby you use it for a period of time and you stop it because it's stopped working. But antibiotics don't really function in that way. Antibiotics are designed to be used for a very limited period of time to treat the infection for which it's been prescribed for. And then there's a natural endpoint to your antibiotics, right? It's not something that you continue indefinitely. So unless there is a reason to suspect that it no longer would be effective, I would say that it should be effective providing it's the right reason and the right drug to be used at that next point in time.
Okay. We've just had a hand, Mary's had her hand up for a short time. So Mary, would you like to ask what your question is? Because it might be pertinent to one of the other questions that's just been spoken to. Just give Mary a couple seconds.
Sorry, I didn't mean to have the hand up. Sorry.
Oh, okay, not a problem. Well, we have just received another question that does relate to the one we just had then. And are there natural treatments or diet interventions to prevent getting IBD? This person has IBS-C, i.e. keep a healthy colon.
Right. And so this is exactly the type of work or research that's really close to my heart. And so I would say that there are at least 7 really large studies in hundreds of thousands of patients or healthy people, I should say. So these are individuals that have been followed over a 20-year period, really healthy individuals, no prior history of inflammatory bowel disease or anything else. And in all of these studies, there are some dietary risk factors that have been identified that can predispose towards new onset disease. And so the current thinking is that intake of processed foods, whether that be processed meats or processed, plant-based foods, intake of or lower intake of dietary fiber, higher intake of sweets or sugary containing foods greater than 100 grams per day. Same thing for salt, higher salt intake. These are all risk factors for new cases of both Crohn's disease as well as ulcerative colitis. Higher intake of meat in general is also a risk factor. And then similarly, higher intake of fruits and vegetables protects against new cases of inflammatory bowel disease. So I would say that this evidence is growing, and especially if you come from a higher risk group. So higher risk meaning there's a family history of inflammatory bowel disease, or there's a family history of other autoimmune diseases like rheumatoid arthritis, for example, or ankylosing spondylitis. Then certainly if you're looking to prevent new diagnosis of inflammatory bowel disease, or you wish to have counseling for your children who may be at increased risk, diet does have a role to mitigate some of that risk. Does it have a role to mitigate all of that risk? No, but because there is a small genetic component that's involved, there's also a small component of altered immunity that's involved that's independent of diet, but you can mitigate a decent amount of risk, potentially 30, 35% or 1/3 of the risk by adopting healthy diet eating patterns.
And I would add to that you're also then benefiting your heart, and you're also reducing your risk of cancers. So you're doing a lot by following those healthy diet principles.
Okay, I was diagnosed with lymphocytic or cytic colitis in 2020. I have been at several of your lectures. I got the distinct impression that you do not consider it to be an IBD, even though it required endocort treatment initially. Where does it fit? Your LyfeMD diet plus daily psyllium and regular exercise keeps it in control, although my long-standing IBS still overrides it with stress or anxiety. Any advice or comments?
Okay, great question. So lymphocytic colitis, and again here you'll see this term colitis pop up. So colitis simply means inflammation in the bowel. It doesn't necessarily distinguish between the type of colitis, and there are many types of colitis. So when we think of lymphocytic colitis specifically, we would consider that as a subcategory of a broader term called microscopic colitis. So just like we're talking about inflammatory bowel disease, which has the subtypes of Crohn's disease and the subtype of ulcerative colitis, there's another type of colitis called microscopic colitis, of which lymphocytic colitis is a subtype. Now, all that means really when we think about lymphocytic colitis, if we were to do a colonoscopy, your colon would look pristine. It would be beautiful and normal and healthy. So looking at your colon, I couldn't make a diagnosis of lymphocytic colitis. So to do so, I would need to take biopsy samples throughout the entire bowel, and then we would have to look at it under the microscope, and then the pathologist who reviews the slides would then make the diagnosis of lymphocytic colitis. Now, according to this slide, I think this interpretation is correct, that lymphocytic colitis is not considered to be an inflammatory bowel disease, even though it requires a steroid treatment like the Entocort that is described here. But in rare circumstances, lymphocytic colitis can form the earliest part of the spectrum of inflammatory bowel disease, meaning that very, very few people that do have lymphocytic colitis can go on to eventually develop the full-on ulceration or inflammation in the bowel. So let's say on average, I would probably make a diagnosis of 5 to 10 new cases of lymphocytic colitis per month. And let's say I make a diagnosis of 100 cases in a year, maybe only one of these will actually go on to develop Crohn's disease. So we tend to think of it as its own entity.
Thank you.
And just to add to that second point around the LyfeMD diet, absolutely. We think that the diet can make a difference in terms of managing symptoms. So the LyfeMD diet, which is really an anti-inflammatory diet, utilizes the same anti-inflammatory principles to help treat the microscopic colitis or the lymphocytic colitis in the same way that we would expect it to treat active Crohn's disease. So the fact that these anti-inflammatory principles translate into both conditions also does argue that ultimately there may be some shared mechanisms or shared similarities between inflammatory bowel disease and lymphocytic colitis.
I was diagnosed with ulcerative colitis in June 2022, just recuperating now, but why do we get joint pain? Why the joint pain moves around? And how can we treat this, as the pain can be debilitating?
Right. So this is another great observation and set of questions. So when we think about ulcerative colitis and why it happens, and same can be said for Crohn's disease, ultimately there is a dysbiosis or an alteration in the bacterial profile that live in the bowel. So historically, we used to think that, or we knew that bacteria lived in the bowel because that's what it does and what the purpose of the bowel is. But I think in 2023, we understand that these microbes in the gut have really, really important functions. And when these gut bacteria are altered in a way, and there are many things that can cause alteration of these bacteria, diet being just one of them, this can predispose towards the inflammatory response. And there are other causes of that inflammation as well. But we think this bacteria is at the crux of it, and a dysbiosis or alteration in the bacteria can impact overall body inflammation, not just gut inflammation. So if one has joint pains, the first step would be to identify whether the joint pain is inflammatory in origin or whether it's non-inflammatory in origin. And if it is inflammatory in origin, you can tell that by whether your joints, how they feel. So are they red? Are they swollen? Are they warm? Does it tend to move around like this question is alluding to? And did it occur in the context of a diagnosis of ulcerative colitis, which in this case it did. So I suspect that this question, this person who asked the question may have what we would call enteropathic arthritis, meaning that they have inflammation that's causing, or their inflammation from the colitis is also translating into inflammation in the joints. So the first step here would be to have it confirmed by a rheumatologist. So a joint specialist. And if they do feel, or if they confirm the diagnosis of an inflammatory arthritis, then the treatments need to be selected to heal both the colitis as well as to heal the joints. So this is a very real finding, and joint pain can be quite debilitating, as this individual is alluding to. So getting you on the right treatment, and because as I alluded to earlier, there are many different choices to treat ulcerative colitis in 2023. Some of these treatment options, they heal the gut, but they may not heal the joints. So having a treatment option that does both is really important.
Why does my heartburn improve when lying down when the logical is the opposite?
I'm going to ask Panita to answer that question because I don't have a good response to that.
No, do I. Normally, heartburn, as the person suggesting, would improve when you're sitting up. But I guess everybody's a little bit different. So no, I'm sorry, I don't have a great answer for this one as well.
Okay.
But maybe I could just chime in and say that heartburn happens for many different reasons. And there is that sphincter at the bottom of the esophagus that is supposed to relax when you eat and then, stay nice and tight when you're not eating. So if there's any lack of, when that sphincter is compromised, that can happen because of carrying excess abdominal weight. It can happen because of having a hiatus hernia. Certainly these things can increase the severity of heartburn. And then if there's a motility disorder, so if things aren't moving quickly, or not quickly, but if things aren't moving appropriately or emptying from the stomach into the intestine, that's another big cause of heartburn. And so typically one would think that when you're lying down, you lose the effect of gravity. And so that's why your symptoms get worse. But all of that said, I can't answer this question either.
Thank you. We're about halfway through the session now, and we're doing really well. And it's nice to have people saying thank you for when obviously you've spoken to their questions. That's really nice feedback to have. So moving on, what other conditions come along with GI issues? For example, eczema, mouth sores, hair loss, etc.
Okay, so when we think about inflammatory bowel disease, so we think about conditions that can affect the gut as well as areas that can be affected outside of the gut. So these outside of the gut issues we typically refer to as extraintestinal manifestations of inflammatory bowel disease. And there's lots of these. So eye pain, eye swelling, eye inflammation. So lots of ocular or eye-based symptoms can happen. Hair loss, as being alluded to here, can happen usually due to nutrient deficiencies. So nutrient malnutrition and nutrient deficiencies can happen very frequently in individuals who have been diagnosed with inflammatory bowel disease, sometimes as high as 75% of individuals may be diagnosed with malnutrition, especially if one is sick enough to be admitted to hospital. So many of these nutrient deficiencies can result in a lot of side effects, including numbness and tingling in the hands as well as the feet. We call these neuropathies. It can affect the joints, as alluded to earlier. Lots of different types of skin rashes, including eczema, but others as well, including things like erythema nodosum, pyoderma gangrenosum, which are active ulcerations that can happen on the abdomen as well as on the legs. And then kidney stones, these are all common extraintestinal manifestations. And then fatty liver disease. So the liver can also be affected both from the disease as well as from the treatment of the disease. And Panita can speak to this. probably much better than I can, but there's a condition in the liver called primary sclerosing cholangitis, which affects the bile ducts in the liver. So this is also a common, well, maybe not common, but definitely a serious side effect if it's observed. Maybe I'll turn it over to you, Panita, to carry on with.
Yeah, so you're right, it is not as common. It's about 5%, I would think, of people with IBD, but it is almost everybody who has it has inflammatory bowel disease. And it is a condition that's more prevalent in men than in women, primary sclerosing cholangitis. But definitely the fatty liver, I would say, is much more common, how the liver would get affected with IBD.
Are there anything else to speak to for this question, or should we move on to the next one?
I think we can move on to the next one.
Okay. How is GI related to ankylosing spondylitis, if at all?
So the response to this question is very similar to the response I provided for the question around the joint pains. So ankylosing spondylitis is an inflammatory arthritis that affects the low back, essentially. And this condition is intimately related to both ulcerative colitis as well as Crohn's disease. You can have ankylosing spondylitis in the absence of inflammatory bowel disease, but more commonly it's observed together. So it is an extraintestinal manifestation of inflammatory bowel disease.
Okay, thank you. I have to take a very large dose of prednisone to manage my recent flare-up. It is causing me major insomnia and very restless sleep. I'm always exhausted and frustrated that I cannot benefit from a nice recuperative sleep. There's no specific question, but do you have anything to speak to? Maybe some advice for this person?
Sure. Maybe I'll start and I'll turn it over to you, Panita.
Sure, yeah.
I think there's two components to this question. Prednisone absolutely is a medication that unfortunately we use all too frequently to help improve your symptoms when you have a flare of your Crohn's disease or colitis. And oftentimes it does work very effectively to help treat your immediate symptoms, but it can have lots of side effects, and insomnia definitely is one of those. But the flip side is many individuals with inflammatory bowel disease do suffer from insomnia, as do many people in general, even without inflammatory bowel disease. So I would be curious to know whether your insomnia only started after the prednisone, or whether you had any component of insomnia predating the prednisone. But regardless, the prednisone and insomnia are features that do go hand in hand many times. So, coming off the prednisone in a way that's safe and getting you on the right treatments for your flare, these are all fundamental and important immediate priorities. But if it has been a challenge to get you off the prednisone, then there are other suggestions one may try to help improve your sleep quality. And so engaging with the yoga, breathing, and mindfulness programs in the LyfeMD application, I'd be curious to know if you've tried that. And if not, definitely I would recommend you consider doing that. Because in fact, in a recent study we published, we did find that the yoga, breathing, and sleep programs in the application were associated with significant improvements for both insomnia as well as fatigue. So I really would encourage you to try those and to work with Charlie and our other coaches to help you implement that. Panita, do you have other comments around the sleep?
I agree with everything you've said. And I think just other sleep hygiene tips. It's so easy for us to forget to, turn off our devices close to going to bed, or do things like avoiding as much caffeine before you're going to bed. So even those simple things, keeping the bedroom for sleep as opposed to for, multiple other activating things, those kind of sleep hygiene tips are also relevant. And absolutely try out the programs. There's a whole sleep program within the application. So something as simple as what I teach my patients is just belly breathing or diaphragmatic breathing, which many of you have probably heard about, but we can take a sec, maybe, Maitri, is it okay? We'll just take a second and do a little bit of belly breathing if you guys are okay with it.
Cool.
Okay, left hand on your chest, everyone. Right hand onto your belly. Okay. And just take a moment. Just feel that. Feel your hands. I want you to start to breathe, but breathe into your belly. So I want you to breathe in and feel your right hand is moving and your left hand should be barely moving. So many of us breathe with our chests, but we want to shift our attention to breathing into our bellies. And so you can lie down when you're lying down, whoever this person is, or any of us really, and do this. You can put your hand on your chest, hand on your belly, and just feel your belly rising up and down. And that in itself really helps to just calm your mind, quiet your thoughts, and get you more prepared for sleep. And you'll find much more deeper practices in the app as well. But that's a good one to start with.
Thank you. Yeah, it's calming.
Yeah.
Okay. How long does a biological therapy start helping? Maybe how long does it take till it starts to help? And how long does it take to cure? Does it help mostly? Not sure exactly with this question.
Right. I think I get the gist of the question. So with active disease, so again, 2023 brings a lot of complexity because we have lots of new medications that we did not have previously. So what the answer to this really depends on which biologic is being started. And there are lots of nuances as to why you may be started on one biological agent versus another one. And the reasons for that may include safety profile, may include disease severity, and like I alluded to earlier, do you have any of the extra intestinal manifestations like the ankylosing spondylitis or the joint pains or anything else? So the answer to this is variable, and it can be as quick as a couple of days to maybe a week, all the way over to needing a full 16 weeks in order to see the full effects of the biologic agents. So this is why many individuals do require prednisone to help bridge this gap. So if your biologic agent works within a few days, of course, that's wonderful. You may not need prednisone, but if it takes 16 weeks to work, then you probably are going to need an element of prednisone to help improve your symptoms to get you through that 16-week period. Now, this next question around how long does it take to cure? So I think if I go back to my original statement, I don't think we can say we have a cure, but we can say we can get you into remission. And so to get you into that remission, it probably is going to be a good 3 to 6 months. And does it help mostly? So we think that biologics can help you get into remission about 2/3 of the time. So 2/3 of individuals will respond and nicely to a biological agent. But still, there's about 1/3 of individuals that may not derive the full benefit and sometimes even no benefit from a biological agent. And so in those circumstances, additional supports are necessary. And those additional supports may be as drastic as surgery, but could be as innocuous as the LyfeMD app.
Okay. If I follow the nutrition guidelines in the app and do exercises regularly, will there be a possibility of my rheumatoid arthritis going away?
Right. So I'm not a rheumatologist, so I don't want to overpromise or overspeak. And definitely the rheumatology space is an area that is, I think we'll be learning lots from this community and our colleagues in rheumatology very quickly. There's a lot of enthusiasm and interest to answer this question scientifically. I think what we can say is that if you follow the nutrition guidelines in the application and you do the physiotherapy exercises, that your symptoms will improve. So will it go away completely? I don't think we can say that yet. We don't have the evidence to say that yet. But will your quality of life improve? Will your symptoms and pain possibly improve? I think the answer to that is probably yes.
Thank you. When do we start reintroducing soluble fiber like apples into our diet to promote regularity in bowel movements and prevent constipation?
Right. So I'm going to assume this question is with regards to an individual that has inflammatory bowel disease or versus something like irritable bowel syndrome, for example, because the answer here is potentially different. But I do want to make one comment, because the science here around fiber and soluble fiber has really evolved significantly in the last couple of years. And I know we always speak the language around soluble fiber versus insoluble fiber, but I think we have to change how we talk about fiber and refer to it more as fermentable foods or fermentable fiber versus non-fermentable fiber. So when we think about fiber, we think about food components that are not digestible by our human cells. So that's the whole concept of fiber. Our body can't digest fiber. So then what's the purpose of fiber? Why does it work? And ultimately, that's because the microbes in our gut, fiber is the fuel for the bacteria that live in our gut. So if we have a certain composition of bacteria in our gut, that will be able to digest and metabolize fiber in a way that liberates the beneficial chemicals and the nutrients for our entire body to use. So I know it's a lot potentially to process at this point in time, but I think as we become more confident in using fiber language like this, I think we'll be able to fully unlock the potential of fiber when it comes to our health and disease management. But to specifically answer this question, soluble fiber typically should not be a major problem in any individual that has Crohn's disease or ulcerative colitis, unless you have been diagnosed with a stricture like Dr. Tandon was alluding to earlier on. So if there is a blockage in your bowel, then we would typically recommend to avoid eating any kind or minimize your intake of any kind of fiber, whether that be soluble or insoluble. But true blockages happen reasonably infrequently in patients with Crohn's disease and ulcerative colitis. So unless you've been diagnosed with a stricture, a true stricture, the benefit of eating fiber, like apples, for example, outweighs the risk of not eating them. So I would encourage everyone to be eating soluble fiber sources unless you have been diagnosed with a blockage. Now, despite me saying that, I know many people will say, well, they still have symptoms after they eat fiber foods. So trying to modify the texture, so blending or pureeing your foods, removing the skins from apples and other fruits before eating them, potentially gently heating them, eating homemade applesauce, for example. These are all strategies that can help improve the tolerability of apples as well as other soluble fiber sources and still retain the beneficial nutrients that can help maintain your remission.
Thank you. And chew your foods. It really helps. Someone has maybe said that would help as well.
That's an excellent point, because digestion starts in the mouth, and it's something we often forget.
Great. Thanks, Amy, for that. Nuts are a good source of protein and of healthy fats, but cause colon inflammation for people with colitis. Is it safe to grind them in a blender and add a tea or tablespoon to my morning smoothie?
Right. So I'm curious by the comment around nuts causing colonic inflammation for people with colitis. So I'm not sure I'm aware of that. I totally agree that nuts are a great source of protein, of healthy fats, as well as the soluble fiber or the fermentable fiber we were talking about in the previous slide. And so nuts can be absolutely a very healthy food choice. Do they cause inflammation? I don't know about that. I would say probably not. But can they cause symptoms? I would say yes. So we just have to be careful about symptoms versus actual colitis. Colitis, in my mind, meaning active inflammation. So to try and improve or to tolerate nuts and to derive the benefit of nuts without aggravating symptoms, I agree completely with the subsequent comment around grinding them in a blender, making it a powder, using nut butters to be able to alter the texture so that you can tolerate it well. Panita, do you have any comments around that?
Yeah, no, I think you've covered it all. That's great.
Okay. How does spicy food such as curry dishes affect the gut microbiome, and are there any benefits discussed in the research?
Do you want to take that one, Panita?
I'm only aware of 1 or 2 small studies, so I'm not aware of any definitive research on this. I don't know, has there been any in this area?
Yeah, and me too. So I think where the greatest benefit I've seen, or not greatest, but the greatest amount of research in this field would surround the use of turmeric or curcumin. And so, yes, turmeric or curcumin, which is the derivative, they have been studied in small studies in both patients with Crohn's disease as well as ulcerative colitis. And they have shown to have to improve inflammatory markers, such as some of the items I shared earlier, so endoscopic markers of inflammation as well as blood markers of inflammation. And that's specifically with turmeric or curry supplements. But in terms of, and typically the supplement doses are quite large, and they're much larger than one would typically apply in preparation of a curry dish, for example. So I don't know that anyone has necessarily studied the effectiveness of a whole curry dish on the gut microbiome. But if we were to extrapolate from what we see in the supplements, potentially there are some changes in the gut microbiome, but I can't comment with confidence based on the existing literature around this topic.
But delicious food nevertheless. Is it safe to eat fruits or vegetables with seeds, tomatoes, cucumbers, raspberries, zucchini, eggplant, etc., as seeds can cause colon inflammation?
Right. So and again, this story gets interesting when we think about what fiber is. So when we think about how fiber, the traditional, how we use fiber in terms of supplements, we're just taking one component of whether it be the fruit or the vegetable or the grain, and that's what we're calling fiber, if you will. But when we think about the whole plant, there's the outside layer of the plant wall, and that needs to be digested first in order to get at the seed or get at the actual core of the fruit or the vegetable. And they all have different beneficial components. Maybe can I just request everyone to mute themselves if you don't mind? Okay, thank you. So in order to be able to digest the fruit or the vegetable or the seed, you need to have the right bacterial players in your bowel. So if you're lacking, or if the composition of your bacteria are in a way that they don't have the machinery to digest the fiber sources, then one can run into problems. So we're just learning about this as a science now. So as this evolves, I think we'll be able to make more specific recommendations on which fruits, which vegetables are beneficial for you as an individual. But typically we will say to minimize seeds, particularly if you have had strictures or blockages in the past, or if you've got active disease. So if you've got a lot of active inflammation, we would say to minimize these things, but to eat fruits and vegetables with the seeds removed and the skins peeled.
Okay, thank you. We've got 3 slides left and there's some more questions, so we might be able to get to everything today. I have a sensitivity to gluten. Is sourdough bread safe to eat for people with ulcerative colitis? If yes, what is recommended portion to prevent a flare-up in my UC?
Right. So this is a bit of a tough question. So I'm hearing you have a sensitivity to gluten rather than a true allergy or celiac disease. Generally speaking, gluten is okay for people with ulcerative colitis to eat. We try and say, if you've got an active flare of your disease, to minimize exposure to gluten. And then as your disease starts to improve and you're on the right treatments, then it's fine to be able to reintroduce gluten sources. But having said that, there is emerging evidence, interestingly enough, that suggests that sourdough bread is a fermentable food, and that can also impact the gut microbes in a way that's friendly to sustaining active disease. So I don't know that we have a ton of data or literature in this field, but based on the small studies that we have, I would say that sourdough bread is safe to eat for people with ulcerative colitis as long as one is in remission. As far as the dose or the recommended portion, I don't know that we can inform that with any degree of evidence, but I would say that you should probably just listen to your body there and try and identify what your body is telling you in terms of how you feel after you've taken or reintroduced the sourdough bread.
Thank you. How do I lose weight on the Mediterranean diet? I've been gradually gaining weight, which I do not want to do.
So I'll be curious to know whether you've been gaining weight on the Mediterranean diet. Is that?
Sorry, I'm just going to mute. There we are.
Thank you. So I'm curious to know whether this individual has been trying the Mediterranean or using the Mediterranean diet and they're gaining weight, or whether they're hoping to lose weight by using the Mediterranean diet. But one thing I will say about the okay, I see a hand up.
Yes,
is that...
I have been following the LyfeMD diet, okay, and I have fought weight loss all my life, and so I was on Dr. Furman diet for a while, then a keto diet before I started the Mediterranean diet. I got down in weight, and ever since I've been on following the LyfeMD diet, I'm gradually gaining weight, and I don't know what you suggest to stop that.
Okay, so I'm hearing you say that your goal is to lose weight. Is that correct?
Well, lose the weight that I've gained since I've been on the LyfeMD diet to get back to where I was. And yes, I've, like I said, I was in the hospital for a month when they took out my colon, and the doctor said, people they're as sick as you are usually are skin and bones. You're not skin and bones at all. I've been that way all my life, and it's just hard for me.
Right. You raise a really important question in that, if you were sick enough to be in hospital, I would worry about, I would worry about the nutrition or the malnutrition component that could be affecting your overall health and health outcomes. So I agree weight loss is an important topic, but I need more information, or I need more nuance to be able to answer that question. But one thing I will say about the Mediterranean diet is that it is rich in fats and healthy fats. So it is rich in omega-3 fats, as well as, optimal omega-3 ratios, olive oil, for example, which is a monounsaturated fat, and certainly fats do come with energy or with calories. So that may be one component. Eating nuts is another component of the Mediterranean diet, and nuts are very rich in important nutrients, but it's also rich in fat. So the Mediterranean diet, some people do lose weight on the Mediterranean diet. It all really comes down to what your baseline dietary pattern or diet eating patterns were. So if you were eating a lot of sort of, I guess, what we would consider processed foods or unhealthy foods. If you come onto the Mediterranean diet, you may lose weight. But if you're starting from a good baseline and you translate into a Mediterranean diet, you may gain weight. So being conscious of the amount of fat that you're eating, trying to decrease potentially the higher fat components, as well as the overall portion sizes, and also simple sugars may be a starting point. But I feel you probably would benefit from talking to Charlie or one of the dietitians in the LyfeMD program to be able to give you personalized advice, because we need more information about your specific circumstance.
Okay, thank you. I will get a hold of Charlie.
Anita, do you have any other comments?
I would just add to that the Mediterranean diet principles also include a lot of, activity, people in that area generally walking around, etc. So not to forget to add those bits in. But absolutely, Charlie will help you.
Take care of it, Bill. Do we have time for one more question?
Sure, last question.
Okay. Oh, it's a long one. I am doing really very well on a keto-like diet. Not so low protein or so high fat as keto, so more very low carb, maybe more correct to describe it. I eat quite high protein and moderate fat. Don't count macros or calories. Stomach is great and no reflux. Blood sugars are so good I can do without metmorphin, so IBS-like symptoms appear to have cleared. Have lost some weight, but very gradually. My concerns are low fiber and sustainability for my health. Any suggestions, opinions, comments on keto or very low carb diets, and if they are okay if your GI tract seems to do well?
Okay, that's a great question. I think that this person has nailed the crux of the problem, which is the low fiber piece. So I don't know if this patient or this individual has inflammatory bowel disease or not. I'm thinking not, because they've referenced the IBS-like symptoms. I think generally speaking, if you are otherwise a healthy individual and you've not been diagnosed with any medical problems, I think in any circumstance, fiber should be optimized. Fiber is foundational to health and to disease. And we do see many chronic diseases emerge, especially with low fiber being utilized in the long term. So I would encourage, unless there's a reason not to be eating fiber, that all of us need to be emphasizing higher fiber choices in our diet. And for men, typically we would recommend between 30 and 35 grams of fiber daily, and for women between 20 and 25 grams, or even 25 and 30 grams of fiber daily. And that's at the low end. So I think it's great that this individual has found a way to improve their symptoms on a keto-like diet, as they've described it. But now that you're feeling great, I think a focus to reintroduce fiber-containing foods in a way that's sustainable should be a priority. And in the LyfeMD app, if you choose the new IBS program, there is a specific program that will help you reintroduce fiber into your diet in a way that will help you keep track of what works for you and how you feel after you reintroduce fiber sources. So I think that this could be a great option for you to explore. And with more fiber introduced, I think there's a lot of benefits that will come with that, including overall better heart health, metabolic health, lower risk of diabetes, lower risk of developing inflammatory bowel disease, better control of inflammatory bowel disease, amongst a whole other beneficial areas to focus on. But I think if you've been having symptoms, your approach sounds very reasonable. You've tried a keto diet, it's worked for you. So now it's time to move on and I think reintroduce the fiber as you've suggested.
Okay, thank you. We are just at 1 minute past 5 now, so we've just gone over our time. So what we will do is thank you everybody for attending today. We hope that we got through nearly all of the questions, which was really excellent. So thank you so much for your input, because without your questions, we wouldn't have had a session. And as Maitri and Panita have said, please do try out what is in the app. If you're unsure of where to start, do book a session, do connect with myself or Chelsea or Alex with Insight in the app. And then you've got some guidance. You've got some ways, some steps how to move forwards with your goals, and we can help work together to reach them. And we also have access to these two very wonderful GI specialists, which is a real unique selling point, I think, for our application, that you have these questions that you can have answered without having to wait for a substantial amount of time. So thank you, Maitri and Panita, for your time this evening. And lots of people have been saying thank you in the chat as well. And we've got lots of positive applause from people, which is lovely to see that it was so well received. What will happen is we'll stop the recording. There's a couple of questions that we didn't get to that came throughout the chat. I'll add those and create a slide, and then